Professor Urmila, you're much welcome to this Africa Health Network Fireside Chat. I'll introduce you to the audience. Dr. Anandh is a senior consultant, nephrologist, and the head of department of nephrology at Yashoda hospitals in Secunderabad. He is prominent in the affairs of the ISN, being a member of the ISN Education Social Media Team, a member of the ISN CME Committee, and also a member of the ISN South Asia Regional Board. She's also heading the secretary. She's also the secretary of the Indian Society of Nephrology, Southern Chapter. It's a pleasure to listen to her talking about the 10 advances in renal transplantation in up to the year 2020. You're much welcome, Doctor.
Thank you very much. It's a pleasure to interact with Africa. Africa has been very close to my heart, and we have been visiting on and off, though it has not happened over the last few years. We get a lot of patients from Africa for our transplants. And if you see this dress, this is actually from Africa, from one of my patients. It's a cloth material which I have stitched as a shirt. So in the next 15 to 20 minutes, as Lloyd wanted me, I'll just discuss 10 advances of renal transplantation in this decade, the third decade of 20th century. Some of these advances are in clinical practice in the developing world. Some of the advances are in the clinical practice in the developed world. Some of the advances are still in textbooks or in journals, and hopefully in the next 10 years or so will be part of our clinical practice. So I'll start with 10 advances. Some of it will be a little difficult. I'm willing to explain at the end of the meeting what it is, because I also don't know much, but I can attempt to sort of work with you and sort of explain things which is happening with transplant in this third decade of 21st century. So I will go through about 10 advances. The first 4 or 5 are actually majorly important, and I will emphasize on them. And next 6, 7, 8, on the last one, we just briefly touch them because of lack of time. But the first 5 are actually now being part of our clinical practice. The first is risk stratification. Every time when we sort of clinically evaluate a set of donor and recipient, the first question that comes in the mind of the patient, their relatives, and doctors, how successful this transplant will be. There are various clinical parameters which we look to stratify: HLA match, the donor and recipient age difference, the donor size, etc. But now over a period of time, we are trying to refine this by using objective evidence. And one of them is to use both donor and recipient genotyping. Certain genes which are extremely important are these genes of ApoL1, caveolin-1, ABCB1. These are all genes for this. ABCB1 are for drug metabolism, and it has been shown that these 3 genes in combination or otherwise in the donor apolipoprotein 1, the caveolin, or the other multi-drug resistant ABCB1 gene is actually associated with graft survival. And one of these, I think many of us are discussing and we know about it, the risk alleles of ApoL1, that is 2 single nucleotide polymorphisms and 1 insertion deletion in this gene, is associated with not just chronic kidney disease, but progression of chronic kidney disease in individuals of African ancestry. This has been studied extensively, and it has been found that patients who have deletions in these single nucleotide polymorphisms, that is DD in 2 that are the 2 apoallele risk alleles. Actually, if the donors with this kind of allele, the DD, deletion allele, are given to a recipient, those kidneys actually fail early. So the presence of this high risk mutation, ApoL1, can tell us that this kidney transplant may not work well. This is being now studied in America, unfortunately, and this study is called Apollo study, where they are now recruiting patients. Recruitment has started from May this year, May 2020. Because of the pandemic, the numbers are not increasing. And this is a study which looks at the genetic mutations in ApoL1 gene and long-term kidney transplant outcome. So this is one way of studying risk stratification. The changes that have happened with HLA typing over the 20 years since I am a nephrologist has been enormous. I will briefly go through them and see how these changes actually have benefited transplantation. When we were students, it was just molecular typing in the 1980s, where we can use only molecular mechanisms. When DNA sequencing of the HLA genes came in practice in 2004, and with automated gene sequencing, now we actually type HLA with DNA sequencings. And what we do is now divide the HLA molecule into 4 subtypes. These are called high resolution HLA typing. When we were students, it was just HLA A02 or HLA B04 or something like that. But if you realize, the A is the major gene, 2 is the first subclassification of the allele. Then you have various field separators. The 101 tells that whatever the gene, what is the specific protein, its structure which is encoded and is present in antigen presenting cells like lymphocytes. Then comes the third sequence, where you see in the coding gene, that is in the exon gene, are there any synonymous DNA substitutions? That actually the substitution can change the structure of this molecule. Finally, we have the differences in the HLA A02 molecule in non-coding regions. So finally, when you type an HLA, the HLA actually should have a 4-figure nomenclature now. In India, we just have moved up to 2, and many countries still restrict to a single number for the HLA gene. Now, what has happened is, when you know a high resolution HLA, and with your computer networks, you can actually put this HLA typing into your computer, and you can develop a three-dimensional structure of the HLA protein which is formed and which encodes or which is found on the surface of the cell. Now, when you have this, then you realize the HLA molecule per se does not matter. There are certain areas in the structure, certain amino acid sequence in the protein which are reactive. And these areas, if it is more than 5, they are called pentaplets. If there are 3 structures, 3 amino acid sequence are called triplets. These structures are of areas of interest, because these differences in the molecule is what is recognized by the antigen cell. And these are called as applets. Now, what has happened is this applet matching has become very important. And there is a software which is called HLAmatchmaker.com, where you can submit all your HLA molecule structures, and that matchmaker brings out a 3D structure for it and delves back to its database and to tell you that whether this HLA, even though it looks with the numbers, are actually matching, but the donor epitope, the epitopes may not be matching. And if epitopes don't match, the HLA typing may be showing a match, but epitope mismatch can lead to an adverse outcome. So we are actually moving from a 4-digit HLA typing to an applet matching. And the importance of this has come in stem cell transplants, where you are taking unrelated donors, unrelated HLAs also. More than the HLA match, what they are looking is the applet match between the HLAs of the donor and the recipient. This has also led to the Eurotransplant program of acceptable mismatch. Now, in highly sensitized patients, they hardly get a donor because of their high levels of antibodies in the blood, anti-HLA antibodies. So sometimes a HLA mismatched, but an applet matched donor is offered to the highly sensitized recipient. And this has actually reduced the waiting time for these patients by 50%. And there are studies which are coming out in abstract form that applet matching actually leads to less formation of de novo donor-specific antibodies. I'll be discussing about donor-specific antibodies in later. This is a meeting abstract from ASTS in 2017-2018, where if the matchmaker shows less than 5 mismatches in the applet, the graft survival is extremely good, and less than 5% people develop de novo DSA. And the survival, this one, the black line, which shows the matchmaker showing less than 5 mismatch. So applet matching seems to offer a much more information about the graft survival rather than the conventional HLA matching. We have always given importance to T cells in transplant. Our drugs are all tailored to sort of cut down T cell numbers and T cell interactions. But over the period, as we realize now, the importance of antibodies in transplant is coming through, and hence we are putting more emphasis on B cells. I will not go through it, but we need to understand the B cells play a role in transplant by recognizing the foreign antigen, taking it, endocytosing the antigen, and then processing and then presenting it through a class 2 MHC restricted molecule to a T helper cell. This interaction between the B cell with the processed antigen and the T helper cell requires co-stimulatory interaction also. This is important when I discuss some of the drugs that are being used in transplantation. And this leads to the formation of antibodies, which are important and play an important role, not just in acute allograft failure, but long-term graft loss. B cell, as we see, are majorly involved in the indirect pathway of rejection, where the antigen is recognized, processed by the B cell, interacted with the T helper cells. The B cell interaction with the T helper cell leads to the formation of the B lymphocyte being converted to a plasma cell, the formation of antibodies. These antibodies actually interact with its recognition site, antigen recognition site in the donor endothelium, leading to a vascular injury, a predominant phenomenon noticed in antibody-mediated rejection. B cell is not only important in acute rejection, but it also leads to the activation of memory B cells at a later date because of non-adherence or less of immunosuppression, and or an acute phenomenon of an repeat antigen presentation leading to large amount of antibodies formation. But in a chronic rejection, these antibodies don't damage or are not endotheliotoxic. They don't cause endothelial necrosis or inflammation. What they lead is to a multiple layering, a chronic vasculopathy, classically known as chronic AMR. I will be discussing this when we discuss the concept of antibody-mediated rejection. Now, with B cells has come the concept of development of donor-specific antibodies. And what has become very important is the presence of these antibodies make a very important role and play a very important prognostic role in overall allograft survival. Donor-specific antibodies have various characteristics, but what is important is to understand some of them interact with class 1 HLA molecule, lead to a complement cascade activation, and they have antibody-dependent complement-mediated cytotoxicity, leading to an acute endothelial damage and profound microvascular inflammation, leading to an acute AMR. This kind of antibody-mediated rejection actually shows the presence of C4d in the biopsy. The other group is the antibodies which bind to class 2 HLA molecule, and usually this interaction of the antibody with the class 2 HLA leads to non-complement binding DSA. This leads to not an activation, a major activation of complement, but leads to a natural killer cell, that is cell-mediated cytotoxicity, leading to a chronic slow destruction of the kidney. So this leads to a chronic or a chronic active AMR, whereas complement-mediated antibodies are usually phenomenon seen in acute AMR. So donor-specific antibodies can be both types. They are class 1 donor-specific, they are class 2. Class 1s are much more classical. They are usually IgG1 and IgG3. IgG3 ones are the most important, leading to endothelial toxicity. These are strong antibodies. They lead to acute phenotype reactions in the kidney biopsy, have a complement activation and shows C4d positivity, whereas a class 2 mediated antibody actually are less stronger and usually of the IgG2, IgG4 subtype, lead to a chronic subclinical destruction of the kidney, and they are not responsive to treatment and responsible for chronic active AMR. So it is not just the antibody, whether these antibodies are complement binding or against which HLA molecule. Important to understand the class 2 donor specific antibodies against DQ have been shown to profoundly affect long-term graft loss. So these are important, against which HLA molecule, what class of the immunoglobulin, complement binding and not, leads to a various different action for graft function. So briefly about antibody-mediated rejection. Antibody-mediated rejection is now considered to be the leading cause of graft loss. It is not the non-immunological phenomenon of IFTA, but a prolonged immunological damage to the kidney which leads to graft loss. And there are multiple phenotypes, as I discussed. The two major antibodies which cause the graft loss is, one, there are antibodies present before, as we see in highly sensitized recipients. And when these antibodies are present and usually picked up with a CDC cross match, and if missed, then can lead to an hyperacute, accelerated acute, and an early acute rejection, antibody-mediated rejection. But if the antibodies are formed later as de novo, they are responsible for late antibody-mediated rejection in this kind of group of patients. Now, to understand the role of antibody-mediated rejection in overall graft biology, it is important to note that in the first 100 days post-transplant, you have the predominant form of rejection is a T-cell mediated rejection after 4 to 6 weeks. This is a milder form, easier to treat, and sort of vanishes over a period of time. If you have antibodies which are preformed from beginning, you land up with an immediate acute AMR like this. But this is a rare phenomenon because we don't transplant anybody who is CDC cross-match positive. And so this acute AMR phenomenon is actually an early transplant phenomenon. But what is important is over a period of time, as the transplant finishes 5 years or 6 years of transplant, then comes the slow and progressive increase in antibody-mediated rejection. Now, this is the major cause, if you look at all causes, which I'll discuss later, of a late graft loss. So the holy grail of nephrology lies in us understanding chronic active antibody-mediated rejection and to treat it and to prevent it if possible. So much so that antibody-mediated rejection in the BAM classification of 2019 has put antibody-mediated changes way up in the categories. Earlier days, it was T-cell and the categories of T-cell, but now antibody-mediated rejection takes priority in the BAM's classification. And the antibody-mediated rejection is physiologically or pathologically divided into 3 groups. One is acute, and the chronic has 2 other groups. This is a newer terminology from 2019 BAM classification. Essentially, to understand acute antibody-mediated rejection is a very angry kidney where there is a lot of inflammation, you have glomerulitis, you have sometimes even because of an endothelial damage, a TMA, you can have arthritis, and you can have peritubular capillaritis like this. So it's a angry kidney where there is a lot of inflammation which is damaging the blood vessels, the glomerular blood vessels, the peritubular capillaries, or even the larger arteries in the biopsy. So if you look into it, you see that, and these are complement mediated, you can see complement deposition, which is seen as a C4D, this immunohistochemistry, the brown stain in the peritubular capillary. These are tubules, these capillaries are stained linearly C4D, immediately alerts us to the presence of a complement mediated antibody directed damage to the kidney. This glomeruli is full. All the capillaries have inflammatory cells around it, occluding the capillaries. The tubules also, the peritubular capillaries are inflamed with large amount of cellular inflames, and the macrocircular, the arteries are also damaged, necrosed with large number of cellular infiltrates. So this is the pathophysiology or the pathology of an acute AMR. Can be treated with plasmapheresis, rituximab, etc. Then you have the chronic. The chronic has chronic active and chronic. Essentially, to understand, the chronic has active has two components. A component of chronicity, that is the chronic glomerulitis, that is actually the glomerular capillaries showing basement membrane multilayering and arterial intimal fibrosis, and also an addition of microvascular inflammation. That is, there is some amount of PTC. This kind of combination is called PG AMR. I will go through this. These are colloquial terms used to understand chronic active AMR. Then you have the final chronic AMR, where there is no active element, there is no microvascular inflammation, but just chronicity. A dead kidney where there is not much of an inflammation, but there is the glomerulitis is chronic, and it shows pretaptular capillary basement membrane multilayering, or the glomerular capillary showing multilayering, and artery, bigger arteries showing fibrosis. So these are the other two, the chronic group. So if you look into the chronic group, you may not see a C4D staining because it's a later stage, and this may not have a complement mediated damage. Where you see is this, if you look into the glomeruli, the last glomeruli, the capillaries were showing studded with inflammatory cells, but here you see the capillaries have thickened wall. There you see there is a multilayering, 2 layers into the capillary wall. Similarly here also. And if you do an electron microscopy in the tubules, classical this is a peritubular capillary, this endothelial cells inside the capillary. The subendothelial layer has multiple layers of damage. So you have a capillaritis, and in the larger artery, the multilayering manifests as intimal fibrosis. So this is chronic AMR, and if there are elements of microvascular inflammation in the capillary or in the glomeruli, then it becomes a chronic active AMR. So we define this from a pathologically mediated that late, these are all chronic AMR are usually late phenomenon in the transplant life, and we define them as PG AMR. That means you have peritubular capillaritis and glomerulitis. That means there is some amount of inflammation happening. I will tell you there are things called rejection classifier. We will discuss this later. Then you have CG-AMR, where you have a chronic glomerulitis, but you don't have a peritubular capillaritis. So this is only no inflammation, but chronic changes. Then you have PG-CG. That means you have peritubular capillaritis, glomerulitis, and chronic glomerulitis. So this one is an acute AMR. This is a chronic AMR. This is a chronic active AMR. Here we have inflammation plus chronic changes. This is chronic, this is inflammation. So we use these 3 parameters to make our clinical decisions whether to treat these patients or not. If you have CG-AMR, maybe even anti-rejection therapy may not help them. And if you look into the lifespan of a kidney, the acute AMR, that is PG-AMR, with the peritubular capillaritis and glomerulitis, is a phenomenon in the early stage, and maybe by this one early stage and sort of disappears. Then comes the second sort of change, this blue line, that is the CG-AMR. That means this is a chronic glomerulitis, that is the chronic active AMR. This is happening over this period of time. The third, which is very important, is a combination of both activity and chronicity, is the most important one, because this subclinical acute antibody, chronic antibody inflammation and chronicity actually is responsible for a graft loss, and this happens and it becomes very important in the later stages. Now, how do we define this? How do we diagnose this in this whole gamut of multiple confusing histology? There are things which help us now for making a better diagnosis. So how do we evaluate rejection? I will briefly go through 2 advances, which both the advances are available in the developed world, and this is available in India. This is called cell-free DNA in transplantation. Now, what we understand is the cell-free DNA is actually in the allograft. The DNA is the donor derived. And if there is some injury happening in this allograft, the DNA is leaked out of the injured cell and is present in the bloodstream. And if you could quantify, these blue ones are the DNAs of the donor, and if you could quantify the percentage of donor derived cell-free DNA, and you have a threshold, a cut threshold, it actually gives you an information that what is happening in this graft. Is the graft happy or is getting injured continuously? So if you have only less than 1% of the whole total donor-derived DNA, I mean cell-free DNA in the bloodstream, and is less than 1%, so there is no active rejection. But then you have lots of cell-free DNA circulating and floating around in the bloodstream of this recipient, then you should immediately alert you that there is something happening and we should be taking action. Now, there are various studies which have been done of cell-free DNA of active rejection. What is the most important thing is this is non-invasive, does not need a biopsy, and hence you don't need to do biopsies every time. It actually can be done frequently. Certain centers in the United States do it every month to look at assess the kidney health, the recipient health. And what is important, unlike creatinine, which may not differentiate between the donor and the recipient in the rejection or not, cell-free DNA can help us do that also. And this, if you look into it, is actually if you have a higher level of less than 1% of cell-free DNA, it tells you that there is an active rejection, whereas the creatinine does not, both in active rejection and no rejection is almost less discriminatory. It is also important to tell us, it alerts us about the presence of an antibody mediated rejection and also severe grades of higher grades of TCMR. The lower grades of TCMR, T cell mediated 1A, may not be differentiated by cell-free DNA, but if you have a higher level of DNA circulating in the blood, then it tells you it's either AMR or a high grade TCMR. Now, this is clinically available with a EA called Yashoda, and this is the report they give you. And if you, for every day, like it is in February, it was 0.67, the percentage of cell-free donor derived, I mean cell-free DNA to the total cell-free DNA. And you see that initially in the early part of transplant, it was a little high, but not more than 1. And it had come down. Now it is rising. So let's see, the transplant happened in February, but in November, it started to rise. So it should immediately alert the transplant nephrologist that this kidney is getting into trouble. So you should be monitoring the cell-free DNA much more and see. And the moment it crosses 1, you should think of anti-rejecting or maybe biopsying this kidney. I discussed about the confusing part of AMR, chronic AMR, and chronic active AMR, and the biopsy may not help us. But then there are certain things called transcriptomics, which is again in practice, which may help us to classify and tell us what kind of rejection is this, is there a graft accommodation, drug toxicity, and infection. So mRNA transcripts is the mRNA which can be detected in a microarray. Large number of mRNAs can be studied. And if you have a sort of a group of mRNAs which are upgraded or downgraded, can tell you, make a diagnosis. So this is called the molecular classifier. So if your transplant suggests this is TCMR, but you're not sure, then you can look for transcriptomics of T cell, interferon, and other cells, and see in your transcriptome if they are upregulated. If these are upregulated, then it is TCMR. Similarly, AMR has its own set of RNA activation, that of endothelial activation, natural killer cells, and inflammatory markers. So if you have AMR transcripts, usually the AMR transcripts are colloquially called ENDATs, that is endothelial activation transcripts. So if ENDATs are high in your microarray, then it tells you that is AMR. It is extremely important because we miss early AMR in our transplants and we don't treat it, leading to late graft loss. So this is being used, where all you should use the transcripts is when there are confusion between a C4d positivity and the biopsy. The biopsy does not tell you that there is a AMR, but C4d is positive, or the biopsy shows it's AMR, but C4d is negative, or the biopsy is inadequate and there is nothing, but you still feel that there is a possibility of an AMR, then you do all the microarray, look at which are the RNA molecules which are upregulated, the NDATs, the natural killer cell activated transcripts, etc. And if they are positive, then it tells you that we are looking at AMR. even in an inadequate biopsy, if they are positive, and then we may, or without even the histological evidence being giving us a clear picture, with this valuable information of NDATs, we can make a diagnosis of AMR and treat it. This has come into the BAMF 2017, where you have any confusion between the histology and the immunohistochemistry, or the evidence of not presence of DSAs and all, then you can always use these classifiers. The classifiers are AMR classifiers, TCMR classifiers, and all this kind of things. Sometimes when we see is a biopsy where there is one artery which is just inflamed, but the biopsy looks like a T-cell mediated rejection, tubulitis, not the endothelial damage. So you worry, this arthritis is part of a severe TCMR, or the arthritis is a marker of an AMR. So this is where an ABMR classifier will help us to make a diagnosis AMR in this patient along with TCMR, because you then need to not just treat the T-cell mediated rejection, but also the antibody mediated rejection. We find this. We also have the endothelial transcripts in one lab in Delhi, especially in situations where we are not sure as to what's happening. Then we have very rarely, because these are extremely expensive tests, ask for this transcripts. Again, available commercially as an allomap. These are the RNA molecules which transcripts are studied, and based on these molecules, they give us a idea how many of these molecules are the RNA transcripts are upregulated, and depending on the numbers, it tells you where are we going. So in this transplant paper, if you see in May, there were only 32 transcripts of mRNA which were activated. And slowly over a period of time, the transcript numbers are coming down. It does not tell you which transcript, but it tells you that numbers are coming down. So it gives you an idea this kidney is settling down, and the chances of rejection is a little less. So this can be also done as a follow-up for patient. Briefly about the drugs that we use. All of us know the commonest drugs that we use in transplant is T-cell, like cyclosporin, tacrolimus, and voclosporin is also being used. And T-cell along with co-stimulatory blockade, belatacept, abatacept have been used in our transplant armamentarium. What is coming in is the use of B-cell directed therapy, because as we understand, AMR and B-cells are slowly, steadily becoming more important than T-cells. So drugs which are coming into transplant use is rituximab. These two, ofatumumab, ocrelizumab, and epratuzumab, have been studied but have not been found that useful. But what is important is we now understand it is just not the antibody, but the antibody's interaction with the complement, which leads to dangerous graft reaction. So eculizumab is now being used in AMR, in HLA incompatible or highly desensitized patients who are going for transplantation, in ischemia reperfusion where antibodies are looking to play a role, and even in delayed graft function where there is a complement activation. So this drug, which is, I think everybody is using everywhere, very expensive, we cannot, but it is a drug which authors are advocating for treatment of AMR. Another group of drugs which I have not talked of is all the other complement mediated drugs, is the C5a receptor antagonist. This is avacopan, which has been recently approved for vasculitis, but is going through trials in antibody mediated complement dependent rejection. Also, the cytokines which have been shown is playing a role is when there is a complement activation, and some of these interleukins play an important role in late AMR. This trial is going on where we use clazakizumab in patients who have late chronic active antibody mediated rejection. Clazakizumab, you are aware, is one of the common drugs now used in the treatment of COVID, but not shown to be that beneficial. Last, we go briefly through the last three. Now, there are patients whom we cannot offer transplant because their blood is full with antibodies. Antibodies which react to whole lot of HLA molecules. They have a panel reactive antibodies of more than almost 95%. Now, how do we give them a transplant? So this is a novel concept where you have antibodies. You use a streptococcal antigen enzyme, that is endopeptidose, inject it to these highly sensitized patients and break those antibodies. This is called immunoglobulin degrading enzymes, or IDEs. And this has been studied in centers, two centers, one in Sweden and one in United States, where they have shown if you give these patients with pre-transplant courses of this IDEs, that is immunoglobulin degrading enzymes of Streptococcus, that has been shown that over a period of time, these patients lose their antibody levels, and pre-transplant they become cross-match negative, and you can safely transplant them. And out of the 25 patients in whom this study has been conducted, 24 now have good allograft function. So IDEs actually help you to undergo HLA incompatible transplants. This is another concept taken, I think, borrowed from oncology, that is called adoptive therapy of T cells, where CAR T therapy is used to destroy cancer cells. The same is used in transplant to destroy virus infections. So what you do is the donor, because we cannot take a third party, but there are studies happening to use third party lymphocytes. If you take those mononuclear cells, expose them to the antigen in the lab, and these cells, the mononuclear cells, react to this virus specific, the viruses, and form specific clones of T cells which can fight this virus, and you get it produced in a lab and inject this T cells derived to fight viruses, and we use this for viral infection. This is being studied and being used in BK virus nephropathy, because we still don't have very good therapies. It is also used in CMV, but CMV has good antiviral drugs for this kind of treatment. But this is being studied and used in BK virus nephropathy. The second last part which we discuss is something which is important for you and for us, is non-adherence. This is something we talk about, but we have never even looked into it and realized how important it is in overall graft loss. If you are non-adherent from the beginning, you developed an acute cell-mediated rejection or an acute AMR, and progressively lead to developing graft loss. But if you have been good for the first 1 year or two and then start being negligent, then you start developing de novo DSS later, and there are subclinical rejections going on, chronic active AMR, lead to chronic active AMR and chronic AMR, and eventually lead to graft loss. You will be surprised to realize that in a study currently which has shown in a transplant looking at left allograft loss, 64%, this makes up 9%, this is 5, 14% of rejections, and 50%, that is 64% of graft loss, late graft loss, is because of antibody mediated rejection. And in this, the major cause in 50% of this graft loss secondary to AMR is because of non-adherence. So extremely treatable and preventable condition which can actually help us prevent late graft loss. There are studies going on to find out how to detect non-adherence and how to treat these people and prevent non-adherence. The last one is a marriage between technology and surgery. This is a nano kidney, a nanotechnological device, which is surgically implanted at the same place where we implant our allograft. The structure joins with the artery. The blood enters this device, returns through the vein, and the filtrate is actually connected to the bladder. This is being studied by Drs. Shubho Roy, who happens to be my cousin, and Dr. Fissel in Shubho comes from UCSF, and Dr. Roy Fissel is a neurologist from Vanderbilt University. What they do, this device actually allows blood to enter into the device for 1 liter per minute. The filtration of that blood, of the uremic blood, is through array of silicon membranes. The filtrate, which is toxin, water, electrolytes, and sugars, are again processed through another bioreactor where there are lab-growing cells like a tubule. They behave like tubules. So at the end of the day, you have all the good things in the second stage reabsorbed back, and all the toxins are formed as a filtrate and removed from the bladder. This is called a nano kidney, was presented in ASN and ASTS last year, is going to be presented this year, and very soon, next year, most probably funding allows, the nano kidney, the first nano kidney will be surgically implanted in UCSF. Now, if you look into the nano kidney, they have developed a cell layer to work and function like a tubule. Now, cell layers have its problems of causing rejection and overall its use long term. Now, that tubular function has been studied extensively, and we realize most of the tubular either reabsorption or excretion is based on physical principles of electrical gradient, concentration gradient, tubular flows, and mechanical gradients. So, and nanotechnology has led into development of wafers. These are called wafers, activated wafers, which actually create an ionic charge and create an electrical gradient between these two levels in the wafer. And when the filtrate, same, a surgically planted kidney, the device, which now, instead of the second stage bioreactor in Shuho's kidney, they have an activated wafer for electric deionization. So the wafer, a layer of multiple wafers forming through which the filtrate passes through, and at various levels where you sort of give electric current or create negative current and lead to removal of the good things like the glucose, and also may remove all the other things. And this can be run 2-3 times to achieve the amount of concentration of the toxins that can be removed, and that can be removed again into either into the ureter or in the bladder. So these studies have shown, and they have shown that these wafers work not completely like a tubule, a complete nephron tubule, but yes, they are good enough in removing the toxins and retrieve back the good things, a function which our smart nephron is good at doing it. So ladies and gentlemen, at the end of the day, yes, I understand there are a lot of changes happening. Over the last 20 years, transplantation has become extremely exciting, but